started. As we, in the interest of time, we'll be starting the session, but keep letting more people join in so that we learn together. Thank you. I'll hand over to Dr. Emma to start presenting the case. Thank you.
Good evening. Thank you, Dr. Ann. My name is Dr. Emmanuel. I'm a second-year resident at Mbarara University. And today I have the privilege to make this presentation to you all, our audience. So thank you very much and welcome. And we are going to start. So briefly, this is a brief history of the case that we have. This is a 22-year-old male patient who was referred from a nearby general hospital with 1 week history of painful muscle spasms, difficulty in swallowing, neck rigidity, inability to walk or sit for about 1 week. And in the emergency department, from our primary survey, airway was patterned and protected. He was breathing at a respiratory rate of 32 breaths per minute, saturating at 98% on room air. He had symmetrical chest wall expansion, central trachea, resonant to percussion with bibasal crepitations. On circulation, he had warm extremities, capillary fill time of less than 2 seconds, a pulse rate of 98 beats per minute, so regular full volume, blood pressure of 144/98 millimeters of mercury, and normal heart sounds, 1 and 2 heart. There were no added sounds. On disability, GCS was 15 out of 15. Pupils equal and reactive to light bilaterally. We noted that he had persistent spasms with a blood sugar of 4.3 millimoles per liter. On exposure, he was febrile. He had dry mucous membranes, and there were no obvious marks or signs of trauma. On getting sample history, signs and symptoms, he reported that he had neck pain, shoulder pain, back pain for about 2 weeks, and a week. Allergies, you don't have any allergies to food or drugs. His medications that he had, paracetamol. Past medical surgical history was unremarkable. His last meal was 12 hours prior to admission to Mbarara Regional Referral Hospital. And the events that led up to his presentation. So I would like to ask the audience if there's any additional information that they would like to know, particularly about this patient leading up to his presentation to the hospital. So any additional information, any questions, any?
Dr. Emma, you have a question in the chat.
That you
Were
would
there
like to
any
know
fevers in the patient?
in the course of his, for the 2 weeks that might have.
Dr. Emma, there is a question in the chat. That,
yes.
Did the patient have any fevers?
No, there was no history of fevers. Oh, thank you. I've seen that from Lydia. No history of fevers. Any other additional question?
Did the patient have any comorbidities?
Comorbidities? No known comorbidities. He was a 22-year-old male who was previously well. before the 2-week history of illness. So no diabetes, no hypertension. Symptoms, of course, were not sudden onset. They were slowly and progressively worsening over the 2 weeks. No, yeah. And no prior history of an upper respiratory tract infection. About the photophobia, we shall see that in a bit. So as we continue looking at the case. So thank you so much for your questions. And I'm just going to give you a bit of the events that led to his hospital presentation. So, but before that, I would like to invite Dr. Joseph Kalanzi and to give us an his expert perspective and opinion on what are his initial thoughts in this patient and how they will approach the patient. Dr. Kalanzi, welcome.
Thank you. Thank you very much for that initial presentation of what the presentation was. As always in emergency medicine, our first thought usually is there something life-threatening in this patient or not? I gave us the primary survey. It looked as though airway was fine, air was patent, the breathing body looked fine. Circulation as well looked okay. What looked a bit off was somewhere the disability where you mentioned some spasms. Then exposure as well, it seemed grossly fine. Initial thoughts is there's nothing life-threatening in this patient at the moment, and I'd like to get a bit more information. For the primary survey, it seems it's still unclear what the cause is of the pain, but at least for the start, there's nothing immediately life-threatening. So I'd like to hear a bit more from what you get from the history as well as your second exam. So if you don't mind.
Okay, thank you. So more about the sample history. So he reported that he was pricked by a dry stick while herding cattle. That is 3 weeks prior to his presentation at Mbarara. That was stuck in the foot, and which prompted him to get local remedies that they employed to remove the foreign body. So he applied ghee around the area and then used a hot iron rod to burn the area to try and see if they can get the foreign body out, which eventually, after 3 days, it came out. And this was followed by progressive swelling of the foot, followed by a weak history of neck pain, later painful jaw spasms, difficulty in swallowing. He had generalized muscle spasms and stiffness, which eventually rendered him unable to sit, walk, eat, or drink. So despite getting treatment from an outpatient facility, which put him on the medication that we had talked about earlier, he did not improve. His condition worsened, prompting his referral to Mbarara Regional Referral Hospital. So of history. Back to you again, Dr. Kalanzi. Any additional thoughts at this point?
Yes, thank you for that. From your history, it does sound like there was a recent history of an injury or a cut wound. And from the description, the cut wound was managed to some degree with poor response. And a few days after the cat wound incident, he then suddenly developed the signs and symptoms that you're describing. So with that history, it does sound like broadly, if we were to look at the broad differentials being something chronic versus something acute, it sounds like we're now going down the path of an acute presentation or a complication of something acute. And broadly, in those acute presentations, we're looking more around just processes versus vascular processes, muscular injuries or something. So yes, I think I have an idea of where we're going. So at this time, I think we're now mostly around the acute presentations of neck pathology. So I will not necessarily say what my differentials are, but I think at this point we're down the tract of something infectious, something vascular, or something around something closely related to the injury that is sustained to the foot. So would you be able to give us the head-to-toe exam findings? Because now I have an idea of the spasms in the primary survey, as well as the history of an injury to the foot. So I'd like to know the secondary exam findings.
Thank you. So let me go ahead and give the secondary survey findings. So in the ED, so before we get to the secondary survey, we did some interventions given that the patient was before us, and given the sample history that we got and the initial primary survey we did. So there are areas that we wanted to address. So airway and breathing, given his presentation, we plan to transfer the patient to ICU due to anticipated need for airway protection and ventilatory support because of these persistent spasms. And we also, on circulation, gave him IV fluids outside with 500 mils of normal saline 4 hourly, and then alternating with dextrose, 10%, since he was not able to feed. To control the spasms, we gave him diazepam 10 milligrams, and we alternate that with IV chlorpromazine 25 milligrams. So we were doing diazepam 10 milligram, and then after 2 hours we do chlorpromazine 25 milligrams. And then we wanted to do pressure area care, and we improvised and put because he was biting his tongue and we wanted to prevent secondary tongue injury, so we improvised with pieces of gauze and put a bite block inside his mouth, and we gave him tetanus, immunoglobulin 500 international units. So we did 250 international units locally and 250 IM, and also called surgery to have a look at his injury on the foot. Pain control, morphine 6 milligrams 6 hourly, metronidazole 8 hourly, and flucloxacillin 800 milligrams 8 hourly were the antibiotics that we prescribed for him. And further on his secondary survey now, this is what we picked from our secondary survey. So head and neck, he had this opisthonous position, and had the grimace on his face, what is called the rhizostomy sardonicus. His chest, he was tachypnic at a rate of 32 breaths per minute, saturating at 98% on room air. It still had symmetrical chest wall expansion, the central trachea, resonant percussion bilaterally of the chest wall, equal air entry and vesicular breath sounds, and head cause crepitations on the lung basis. His abdomen had normal fullness, was moving with respiration. There was mild generalized tenderness on palpation, no organomegaly, with normal bowel sounds. Then moving further to his extremities, he had spasms involving the upper and lower limbs, back, that would occur at about every 3 to 5 minutes, with his upper limbs adducted at the shoulder and flexed at the elbows, and the lower limbs extended at the hip and knee joints. Neurologically, his GCS was 15 out of 15 throughout the whole interaction with him. He remained GCS 15 out of 15 and had 3 millimeters pupils bilaterally with global hypertonia. And then on the foot, the area where he had the injury that he sustained 3 weeks prior to presentation, we noticed that there was a dry, non-discharging scar on the plantar aspect of the right foot that was about 1 centimeter by 1 centimeter, with a central hyperpigmented area and normal surrounding soft tissue, and there was no tenderness on palpation. So that was our secondary survey that we had. Those are the findings that we picked from the patient. Then in investigation-wise, for this patient, we were able to do his serum creatinine, which was 0.52 milligram per deciliter. That's within the normal range. I think the range the lab gave us was 0.7 to 1.3. His urea was 10.8 and a range of 10 to 50. And urinalysis, there was no abnormality that was detected. And one of the reasons we did this is because, given the spasms, and we also noted his urine bag had about 200 mils of dark urine, we just wanted to rule out any possibility of acute kidney injury. Yeah, so at this point, I want to invite Dr. Kalanzi again to give us his expert opinion on what would be the gold standard versus what we have in our settings, given that we are mostly in a limited resource setting, and also approach to management of this patient. Thank you.
Yeah, thank you very much for that. Thanks for the detailed head-to-toe findings, as well as the management plan that you followed. Yes, as indicated, I had a feeling it was something to do with tetanus, mostly because of the acute onset, but also because of the history and physical exam findings. Physical exam findings primarily in instability, where we spoke about spasms, were indicative of possible tetanus infection, but also now with a history of a cut to the plantar side of his foot that wasn't managed well, also it's very suggestive of tetanus. The spasms you indicated on the second exam were also quite helpful to making the final diagnosis. And so yes, tetanus definitely would be on the list. There were a few other differentials that someone would think about in a patient that has a similar history. But coming from your primary assessment findings, as well as your history, sub-history, and second exam, the findings tie in very closely with tetanus. There are a few others that could have been on my differential list, such as meningitis. Okay, meningitis would be ruled in mostly because of the acute onset, but also because of the spasms, not linked to any the dysphagia wouldn't necessarily be an associated feature, but the pain in the neck and the short duration of time would have possibly brought about meningitis. To rule it out was the fact that you didn't have any hypertonicity or positive Babinski sign or Koenig's test. I was trying to listen out for that, but as you mentioned in your findings, it wasn't identified. So that would rule out the second possible differential. A third differential would have been something vascular. So you'd be thinking something around something around the spinal arteries. The spinal arteries could be coarcted, that could also, or dissected, that could also present acute onset pain. Then thirdly would be something around deep muscle infection. So sometimes patients that might have some kind of abscess in the neck region could also present with similar presentation, but deep muscle infection abscesses wouldn't necessarily have dysphagia or the positive history of the injury to the foot. So yes, so just as a group to think about the other differentials, this one was a bit very leading because the positive spasms and the positive history of infection of an injury was quite direct, but with something as direct as that, to be able to rule out other possible causes. Okay, like mentioned, those that could be either other similar infections or something vascular, or if in the event that this had taken a much longer time, something more chronic would have thought about something more acute again, would have been some form of disc prolapse. So even as we have a much more clearer diagnosis from this, it's also very important that as we examine, we rule out other possible differentials in our setting. So in our setting, with that kind of history, our most likely diagnosis in this case, which was a tetanus infection. In terms of the approach, again, glad that you followed the procedure we use in the emergency setting, where you did the primary survey with interventions, and I was happy that you did notice that the airway was patterned, but that you anticipated, because of the spasms, the dysphagia, that there was a possibility that it would easily progress to possible obstruction, again, because of the spasms and difficulty to swallow, and you anticipated the need for possible ICU. So in some cases, some of these patients would need an advanced airway in the event that the spasms have increased and you're unable to control the spasms in the so that was good that you anticipated that. Sometimes the patients do present with increased secretions. So the secretions as well, you might have planned for possible suction for these patients, because sometimes they'll be salivating quite a bit, so suctioning could be useful. In terms of breathing, luckily he was at this point still breathing spontaneously and didn't have extensive restriction to his chest cavity, and so the management was standard. But again, in advanced forms of the condition, they might have extensive spasm that affects the ability to ventilate appropriately. So in that case, the possibility of assisted ventilation is important. If they haven't reached that point, at some point, they might also just be in a lot of pain, as well as fatigue from the extensive spasms. So in the event that you decide to sedate them and put them to sleep, assisted ventilation would be an option, like is indicated for patients that end up in an ICU. So planning for that anticipated need for supported care is important, which you mentioned well. The circulation, their parameters seem to be in order. The primary survey, my consideration would mostly be around that come in either with who have not been able to feed and are not drinking at all. Again, because of the extensive energy lost during the spasms, sometimes you might want to consider IV fluid resuscitation. Again, because sometimes you reach a point when they will not be able to take it orally, and any attempt to feed them would cause would worsen the spasm. So for those cases, you might want to have IV options. Also in the C, again, immediate IV access is critical, as you mentioned, because you're going to be using quite a bit of medications for the spasm management. In D, I did notice you mentioned the findings from the level of consciousness. He was fully conscious, and therefore there was a need for much there. His glucose, I would have wanted to know what the glucose was. I probably missed it, but in case it was hypoglycemic, I'll look out for that. But the bigger one was the increased spasms And I'm not sure if you did mention seizures, but spasms are a big problem, which you also addressed in D. In E, I'm sorry. So yeah, managing spasms, which you did manage in this case with benzodiazepine, diazepam, as well as chlorpromazine intermittently is the gold standard. So excellent on that. Then on exposure as well, you did mention there was some wound care that was done around the foot of the patient's foot and the injury. So cleaning the wounds, and then two, I can see that glucose was 4.3, excellent. So that was noted, and we kept that euglycemic range. And then for E, which was the spasm and the wound that you found, you also indicated that you administered tetanus immunoglobulin directly at the site, but also in other cases, if the patient wasn't vaccinated at all, or if the vaccines weren't up to date, what I'll do as well would update his tetanus vaccine. That would be my initial approach in the primary survey. And of course, because of the diazepam and chlorpromazine, I'd have a bit more precaution around managing his airway and possibility of assisted ventilation in case we went into very high doses of the benzodiazepine. So in a nutshell, I think that was good in the primary survey. In the workup, yes, you did cover all the points. I noticed that you did mention the screening you did. There are no definitive, at least in our setting, we don't have definitive screening to identify the exotoxin that is in the blood system by Clostridium. But you can at least see for the acute phase reaction parameters that can indicate infection, so, which you did. There's really not much you do in our setting aside from the clinical findings or clinical symptoms to make the diagnosis. So a lot of it is what you physically see as well as from the history. So from my perspective, what you did follows the exact treatment or management standard. Though in other settings, they might have immediately put this patient into an isolation area, taken them away from the emergency department, put them in an unenclosed area to prevent cross-infection between that patient and other patients in the emergency department, as tetanus is considered a very highly infectious condition. And then two, would have been extensive IPC intervention, IPC measures used for this patient. They event that there are other patients around. So broadly, those are my thoughts about the case. Thank you.
Thank you, Dr. Kalanzi, for the input. It's extensive. Just to keep the house in check, if you are logging on this call, kindly mute and turn your video off so that you do not interrupt the session. Thank you. Over to you, Dr. Emma.
Thank you so much, Dr. Kalanzi, for that input. That was wonderful. I'm just going to give you a bit of what happened to the patient in the emergency department and also when they went down to the medical ward. So in the ED, he still had persistent spasms that were easily triggered by movement and sounds. And there's we noticed the following day that he had actually missed his chlorpromazine dose as we had run out. So we actually got internal medicine to come and review him. And we also reviewed his medication chart, transferred him to, I want to say a makeshift isolation area, stayed inside the emergency department, but an area that has, reduced stimulus. So it's dark and there's restriction of people that actually go there to control the spasms. But that happened the following day. So when we saw him, he still had this hyperextended neck. He wasn't in distress. GCS was still 15 out of 15. He was fully awake with occasional spasms. And his vital signs, he had a pulse rate of 92 beats per minute, saturating at 97% on room air. Blood pressure was 138/84. And then he had this about 100 mils of dark urine in the urine bag. That's when we actually did his labs to see what was going on, because we were thinking could he actually be getting complications as a result of the continuous spasms? So we continued the diazepam, chlorpromazine, fluids, got a gel that has chlorhexidine and lidocaine gel because he had a lot of quite significant lesions on his tongue, and continued with antibiotics, metronidazole and ampicloxacillin. Yeah, and we also got internal medicine to review the patient. So during his hospital calls, we didn't get because he's after about a week, the frequency of the spasms actually improved. So we didn't get to a point of actually sending him to ICU. So the isolation and the medications were really worked well for him. So a week later, when we saw him, his frequency of spasm had significantly reduced. He was actually able to sit up in bed and talk. Vital signs were good. BP of 117/69, altitude of 112, and saturating at 98. And the plan at this point, we now brought in physiotherapy to help with his rehabilitation. Still continue with diazepam and chlorpromazine, and had the patient now transferred down to the medical ward because we still had him in isolation in our emergency department. So that briefly was his hospital cause, and about a week later, that means now his second week of being in the hospital, he was actually discharged home walking. So at this point, I'm going to invite Dr. Kalanzi again to tell us about the pearls and pitfalls when it comes to management of these patients that we get. Thank you.
Dr. Emma, briefly, maybe before Dr. Kalanzi comes in,
Yes.
could there be any concerns in the audience? Any further thing they would love to know about this case, or challenges, experiences, just over the next 5 minutes? We could maybe hear from the audience, then Dr. Kalanzi can give us the pearls and the pitfalls.
Okay, thank you so much. So we thank you for that reminder. So I'd like to hear from the audience if there's anything more that they'd like to know about the patient. And as Dr. Anne has put it, where is this?
Okay, it looks like the audience is set. Oh, there's a question. Consulate Opar is asking, how does sound and light exacerbate the muscle spasms? That question, that I think will be handled by the experts in his pearls and the pitfalls, I think. Dr. Jimmy Atiera.
Yes, thank you, Emma, for the nice presentation. I'd love to know how easy it was for you to get the tetanus immunoglobulin, and how easy was it for you to get it? Did the patient have to buy? Was the facility having it? I'm just curious, like in case I have a patient of tetanus, how readily available in the emergency department will I be able to get?
Thank you for that question. We actually have the tetanus human immunoglobulin in our emergency department. We have in our research room, there's a fridge that has some medications. So we actually have it in stock. The patient didn't have to buy it. And we got that supply from our pharmacy. So I'm now not sure if in other facilities it will be readily available as we have it in Mbarara. Thank you.
Okay, thank you. I think the audience has exhausted. We would just get one more question or opinion from the audience, then we hand over to the expert. Okay, looks like the audience is satisfied with the care that Mbara gave to this patient and the lessons that have come through with the patient. So over to you, Dr. Kalanzi. We already have a question that I thought should be coming in your pearls and pitfalls. How does the sound and the light exacerbate the muscle spasms? Over to you, Dr. Kalanzi. Thank you.
Very much. Yes, about pearls. Just like we do for any other presentation we have in the emergency department, which I think was really well followed in this case, is one, have to make sure that we are safe. And I know we usually rush to this patient if they don't have very clear features of being soiled, i.e. bleeding and all. Most times you might put our IPC considerations out of the window, but as you said for this case, if you hadn't been cautious, there's a very high chance that the person, the team that saw this patient might not have had their considerations for their personal safety included. So this was just a reminder that conditions such as tetanus might be obviously highly infectious, but as you've seen, you only discovered at the end of the assessment that this patient actually had something that could easily be spread to the medical team. So as a reminder, we always have to make sure that our safety considerations have been considered. That is safety of yourself, but also safety of the environment in which you're managing the patient. And so putting on gloves, as well as in the event that if there was something a bit more alarming, maybe having worn a gown would have been important. And then ultimately, when they discovered that this patient actually had tetanus, as you notice, the IPC, the infection prevention and control intervention was stepped up. Okay, the patient was isolated, as well as I'm sure very, very unique IPC measures were introduced in some settings. It means indicating that the patient in that bed is highly infectious. Please make sure what is used on that patient is not used with other patients. Make sure that you wear gloves. Make sure once you use items on that patient are disinfected. Okay, so that was something that stood out for this case, again, because it's not an obviously highly infectious patient. So one, being always ready and cautious of your safety is important. Number two is the primary survey. For this case, the management of the patient's primary survey findings was symptomatic. Okay, was supportive. As you noticed, we went through airway. The airway, there was nothing, but we had a presumptive or anticipation, rather an anticipation that there's a possibility that this patient would need an advanced airway. So for the students, for those that wouldn't have seen any airway obstruction, it was important that when we discovered that this patient actually had a spasmic condition that would ultimately affect his airway, we anticipated the need for ICU admission. So for patients that have tetanus, it's important to have that at the back of your mind that there's a possibility that they might ultimately need intensive care with an advanced airway because of possibility of rigidity in the neck muscles or in the jaw muscles affecting their airway. And also suction. For breathing, as indicated, sometimes they might have progressed towards difficulty in breathing, which again was anticipated in this case. They were supportively managed, with spasms. But in some cases, again, there might be advanced cases where there's extreme rigidity or spasms that you need to put this patient under general anesthesia. And in those cases, having your contacted ICU or high dependence unit to anticipate admission there is important. C, this case, it didn't really need much intervention for C, but at least we took out blood samples for some tests. D, where the bigger problem was about managing spasms. And there are different combinations of medications that can manage spasms as well as rigidity. So in this case, benzodiazepines are first line. as well as chlorpromazine in our setting, as well as sometimes muscle relaxants. So there are some muscle relaxants that can be added to the combination of the benzodiazepine and the CPZ. So sometimes, depending on what you have, you can include a muscle relaxant. So the common one we have in Uganda is Myospars. It also has a good effect on. So that is part of the care. But the pearl is that you use them interchangeably and provide them in alternate administration. So in your 24-hour schedule, you would interchange between chlorpromazine and diazepam, switch to chlorpromazine, diazepam, but again, all the time looking out for potential respiratory depression from the benzodiazepine. Another big one that is always used is managing the site of infection. So both local site as well as systemically, as was indicated there. So wound cleaning or wound identification, number one, but as well as wound cleaning or wound toilets is important. Site does not continue to expose the patient to the endotoxin. Then systemically, as we know, this tetanus is caused by Clostridium, which releases an endotoxin into the body, which generally has effects on the autonomic nervous system, which causes a salivation as well as the photophobia, but also motor and sensory effects looked at as the spasms. So the role of the antibiotic is to neutralize the endotoxin that is circulating across the body. Some of the questions asked at some point was, what was the best antibiotic for this? And so generally the drug penicillins or metronidazole that has a good efficacy on Clostridium. Other drugs that have been suggested that can be complementary include vitamin C, but there's not been any benefit from vitamin C, and just a strict adherence to dose of metronidazole over a couple of days with concomitant anticonvulsants as well as the muscle relaxants has been shown to be important, but it's important, like I mentioned, to ensure cleanliness of the area. So surgical toilet should be done to the wound. In some cases, if it's extensive, you might want to involve the surgical team to do a complete debridement. But in most cases, it's usually a small cut wound which might be treated by the EM team in the emergency department. If you discover that it's extensive, please involve the surgical team that will come along and do much more extensive debridement and deep wash of the wound. In some settings, they've been applying topical antibiotics, but there's really not been any benefit. And the systemic antibiotic, especially metronidazole in our setting or a form of penicillin, does just fine. In terms of managing the environment, there are various triggers as mentioned in this case. So it's important, one, that the patient is isolated, kept in a quiet environment without light, because of the hyperexcitability of the autonomic nervous system or the derangements. Any small triggers like noise, sounds, or light, or even touch itself can exacerbate the spasms. So try to avoid those. In some settings, advised if the patient cannot tolerate an NG tube, wait until they are a bit better or sedated for you to introduce an NGT, because actions like that as well can exacerbate spasms. So finally, my parallel is around the index of suspicion, but as well as the use of a full primary survey with supportive care. And more importantly, or as important, is getting a full history about why this patient had the presentation they had. And then finally, which is the head-to-toe exam, is a detailed exam from head. And luckily, in this case, the defining lesion was found in the foot. Head to toe is extremely important, and even though the patient has spasms, it's important that you properly examine them. You might only have made the diagnosis at the examining of the foot, so it's always important, and we keep reiterating this to everyone that is by ED. Make sure you do full exam. The exam is not complete until you've done a full head to toe. And just to conclude, patients like these, depending on their presentation, can progress well, and actually, like this patient, get discharged, and unfortunately, some others might not. So some others might come at a point in which the disease has spread very extensively, and therefore might need immediate ICU care. So be ready to transfer them to an ICU. Be ready to transfer them to an ICU, and if it's not an ICU, be ready to provide supportive care and full-time monitoring from the moment you make the diagnosis to the point at which you can safely hand them over to the team. So those are my powers and pitfalls. I hope this was useful.
Thank you, Dr. Kalanzi. Dr. Emma, would you want to take on from here?
Yes, please. Thank you, Dr. Kalanzi, for that very nice summary. So I just have, I hope it's not going to, just a few take homes from this case. The goals of management, as have been highlighted: antibiotics, therapy, control of spasms. And then one thing that I think we did well for this patient was neutralization of the unbound toxin using the tetanus human immunoglobulin. And then wound care, which has already been talked about. And the other bit also is anticipate where the patient might, how they might progress. So it is also good to involve critical care early in the course of the patient hospitalization process. And then we know that there are populations at risk. So neonates, of course, are at risk of getting neonatal tetanus, especially those who have been delivered either in home deliveries or where deliveries have been done under environments that are not aseptic. So we need to take note of umbilical stump infections, usually in the first 10 days of birth, and then individuals who have not been vaccinated, because we pregnant mothers and young children often tend to get these vaccines, but especially the male population do not frequently get these vaccines. So those are also at risk. That's why when the patients come in with trauma, we want to give them the vaccines. And then recent injuries, so pick that from a history. In septic abortions, IV drug users, though not very common in our populations, and then surgery, of course. Then finally, neonatal tetanus will present with poor reflex, suckling reflex, grimacing, or irritability. So the 4 forms, we have neonatal, cephalic, local, and then generalized, like what the patient that we just discussed had. So also take note of these presentations when the patients come to you in the emergency department. They will not always have the generalized form of spasms as we've just discussed. It will have local, where you just have the local muscle groups that are close to the site of injury, or cephalic, especially after head injuries, or otitis. So they'll just come with cranial nerve 7 palsy. And I would like to acknowledge Dr. Tracy, who mentored this presentation, and our moderator, Dr. Ann. So Dr. Tracy, do you have any, I'd like you to just say a word for a minute, please.
Thank you, Emmanuel. Great presentation. This is a very interesting case. I think one of the 2 points that I took home from assessing this case was, one, I had airway concerns, as Dr. Kalanzi had already spoken about. partly because this gentleman was chewing on his tongue with every spasm, and I was kind of concerned that he might even bite off his tongue and end up with blood pouring down his airways. So that was another consideration for us. And number two, this gentleman was basically locked inside his body that was spasming throughout this sort of at least 1 week history. And it was, I can only imagine how distressing that would be from a psychological point of view to have this degree of pain and discomfort and not be able to do anything about it or necessarily be able to communicate very well to the people looking after you. So again, as Dr. Colanzi said, even for humanitarian reasons, sometimes thinking about early intubation to be able to provide enough pain relief, analgesia, antispasmodics, etc., to be able to alleviate this person's the degree of suffering. So those were just two extra sort of highlights that this case left me thinking about afterwards. So thank you very much for this opportunity to discuss what should be an entirely vaccine-preventable diseases, and I hope it prompts everyone in the audience to go out and get their vaccines updated as well. Thank you.
Thank you, Dr. Tracy. Thank you, everyone, for joining in for this session. We have about 5 minutes to bring this to a close. I hope all our questions were answered. And in case anyone has a question, I'll give 1 minute to the audience. In case you have a question or an issue that you feel was unaddressed, kindly unmute and raise it up with the next 1 minute. Okay, there is none. Thank you everyone for joining in. Special thanks to the Mbarara Emergency Medicine team and generally Mbarara University, Makerere University, Seed Global, FUMSA, and everyone who has joined in for this session. We thank you for being part of us. And just a reminder, these sessions happen at least twice a month. And in case you get interesting cases out there, feel free to reach out to us. We'll be glad to learn from them, just as we've learned today and been reminded that tetanus actually still exists and people should get vaccinated and we should have a high index of suspicion in our ED. Thank you once again to the organizers. Dr. Boni, I know he may not be able to unmute at the moment, but thank you for putting this together. And for our expert, thank you for giving us for helping us or for allowing us to dig from your well of knowledge. To the presenter, thank you for taking on time to organize this wonderful case. We hope more people can take up the initiative to bring us more cases to learn from them. Thank you, everyone. Bye. See you next time.